Welcome everybody, good afternoon. So on today's Public Health Forum, we decided to do the right thing and tackle an important issue that is often not popular in public health, which is measurement, which seems to be not popular in the school as well, but it is still important, which is why we're talking about it. And we are truly delighted to have Marcia Wilson talking to us today. So just a few words about Dr. Wilson. She is Senior Vice President of Quality Measurement at the National Quality Forum. She will tell us about the NQF in her talk. But broadly, it's a not-for-profit membership organization that aims to catalyze issues around healthcare improvement through measurement and reporting. She leads the core NQF activities in measure endorsement and measure selection. Before NQF, and she's actually been at NQF since January of last year, her work has focused on quality improvement initiatives in healthcare, and she's been doing that for a long time, actually. In particular, for about 15 years, through leading Aligning Forces for Quality, which is an RWJ project. She also has been in healthcare in medical groups for a long time. She has graduated from University of Illinois, University of San Diego, and George Washington University, where she also was for several years before joining the NQF. And she's spent the day with us, had a number of conversations, including with students, and we're delighted to have her. Marcia.
Thank you so much. I'm delighted to be here, and I particularly want to thank those of you who spent time with me today. We had some great and far-ranging conversations. So I'm going to start my presentation by making a confession, which is in terms of appreciating the value of higher education. I was a late bloomer, a very late bloomer. I'd worked in San Diego in healthcare for about 20 years when I decided to go back and get my MBA. And somewhere in that process, I decided that maybe I wanted a PhD. I didn't know really what it was, but it sounded very interesting to get one of those. So shortly after my MBA, I went to the George Washington University, where I did my PhD in Health Services Administration. And one of the reasons I ended up at GW is they would allow me to go part-time, because I wanted to work while I did my PhD. And I worked in the Department of Health Policy, and as you heard the dean say, a lot of my work there was not the typical academic work. I worked on quality improvement projects in hospitals and communities. So I guess what I'm telling you is I was an atypical student, I was an atypical academic, and you're certainly going to see that in my remarks today. So, insights on population health measurement. So this is what we're going to talk about today, and I want to tell you two things as we get going. First of all, I assumed this audience would be mixed, staff, faculty, students. So I wrote it with that kind of audience in mind. The second thing is, this talk is not geared for Boston or Massachusetts. You are an outlier in many ways. I consider Massachusetts and the Boston area to be very well resourced. You got a lot of data, you got a lot of legislation, you've got a lot of innovative projects going on. So if there's any students in the audience, when you leave Massachusetts, that's not the way it is in other states. Massachusetts really has tremendous resources, so this presentation is not necessarily written for Boston or Massachusetts. Now, when I was at GW and I was writing something, one of my professors said to me, Marcia, it is not a mystery novel, tell the readers how it ends. So I'm going to tell you how it ends here. Key message number one, population health is a team sport. You cannot do it by yourself. However, the responsibility is shared, but the accountability is diffuse, and this makes it very, very tricky. Key message number two, measurement. The dean said you don't like measurement. Maybe you'll like it a little bit better after this talk. Measurement is a critical tool for helping you get where you want to go. So, for those of you who aren't familiar with the National Quality Forum, we are a membership, nonpartisan organization based in Washington, D.C. You can see our mission statement here, and our work is all about performance measurement in healthcare. So on this slide, I've got three words I want to talk about. The first is transparency. Everything we do is in the public domain. You can attend all of our meetings virtually or in person. You can comment on all of our reports. You can make comments on all of our measures that we look at. You can make comments on the slates we put together for our committees of experts. everything we do in the public domain. We're also multi-stakeholder. We have over 430 member organizations. They represent providers, purchasers, health plans, the supplier industry, consumers, patients, pharmaceuticals. It's multi-stakeholder. We also have almost probably 500, 600, 700 volunteers that come and sit on our committees to review measures, to talk about measurement, and these people also represent all the different stakeholder groups. And the last word is consensus. We are a consensus-based entity, and that means when we're reviewing measures, we've got to come to consensus. Now, consensus does not mean unanimity, but it does mean that every voice has to be heard. So when you put multi-stakeholder and consensus together, you get some very interesting discussions. So if you look at the measurement life cycle, this is where NQF has some of its work. Now, one thing we don't do is we do not develop measures. Other people develop measures, and then they bring those measures to us for what we call endorsement. We convene committees of experts to look at measures in pulmonary, cardiovascular, person and family-centered care, health and well-being, renal, the list goes on, and they review the measures. They look at the evidence behind the measures, the reliability, the validity, the usability, and the feasibility of the measure, and if that measure passes muster, the committee recommends the measure to be NQF endorsed. Another thing we do is in the next box over, measure selection. We currently have a contract with the U.S. Department of Health and Human Services to look at measures that they're considering putting in their federal programs for all kinds of providers. These programs are for public reporting or pay for performance. Again, we convene experts. The measures are given to those committees. They review them, and they recommend to HHS whether these measures should go into programs. The framework for what we do is the National Quality Strategy. You're probably familiar with this. It's a national blueprint that was put forth by AHRQ, the Agency for Healthcare Research and Quality. I'm trying to live in the acronym-free zone today and explain any of the acronyms that I use. If I don't, you can call me out on that. And you can see here in the NQS the 6 priorities or strategies in the center, and they are guided by the 3 aims of better care, smarter spending, and healthier people. The original performance measurement work in healthcare was all about measuring the quality of care. And it really began in the early 1990s when NCQA, the National Committee on Quality Assurance, got performance measures from health plans and reported those measures. And then towards the latter part of the 1990s, a lot of providers started using measures for quality improvement, looking at measures to see if the care was getting better. Now, I was working in healthcare in the 1990s. I thought we were taking pretty good care of our patients. Then, of course, the Institute of Medicine published To Err is Human in about 1999. In 2001, it followed with Crossing the Quality Chasm. And clearly, we were not taking as good of care of our patients as we thought we were. So one thing to think about is quality and performance measurement is really a baby when you look at public health. We are so much more nascent of a field, although sometimes it feels like we're a teenager with all the legislation and changes that's been going on, all the drama and angst of the last 5 years. But compared to public health, we are much younger. Now, back at NQF, I work with a great team of very smart, very hardworking, very dedicated people who like nothing better than to geek out about performance measures. So I'm going to have a couple of slides about measures so you too can geek out with performance measures. So what is the role of the measurement? As I said earlier, it's not the end goal. It's a tool. It's a means to an end. And a measure, it can be a standard, a basis for comparison, or even a reference point. And at its best, a good measure will drive improvement, it will inform, it will influence. So the very basics of a measure, it's a numerator over a denominator minus some exclusions. And this framework on the bottom, this type of measures, is actually from Donna Bedian, and you probably are familiar with the quality framework from the JAMA article 1988. And some of you will be very familiar with these measures, but I know not everyone is, so let's walk through them briefly. A structural measure is about characteristics of a provider or an organization. So if I'm a patient with diabetes, a structural measure might be the percentage of providers that can identify all the patients in their practice with diabetes. Now that's important because if you have diabetes, you need to come in for routine periodic checkups with your doctor. The process measure is what happens to the patient. As a diabetic, did my doctor do a hemoglobin A1C? Did the doctor check my blood sugar? The intermediate outcome is the results of that process measure. Was my blood sugar under control? And then finally, a little further down the road, an outcome might be what I as a diabetic patient say my functional status is living with this disease. Now, I don't see why we couldn't either expand this framework or run in parallel to this framework population health measures that also would be relevant. So say, just continuing with this diabetes theme, say an intermediate outcome under population health might be a lower incidence or prevalence of diabetes, and an outcome measure might be fewer deaths before age 75 from diabetes, or in an improved quality adjusted life expectancy. I don't know if those boxes follow or they run in parallel, but we are measuring slightly different things here, so I want to call that out. I want to spend just a bit of time on this slide. Some of you will be very familiar with this because there are implications for population health in this slide. In early 2015, Secretary Burwell from HHS announced some very ambitious groups of how they wanted to change payments for providers caring for Medicare fee-for-service patients. And that's what this graph is talking about. As you move from 2011 to 2018, what CMS wants to do is shift the number of payments to providers that are linked to quality and/or alternative payment models. So that top number is the ultimate goal, and then that lighter green box is the percentage within that goal that are alternative payment models. So what's an alternative payment model? It has to do with value-based purchasing. And very simply defined, value-based purchasing is moving from paying providers for volume, the number and type of services, to value, which is increasing the quality while lowering the cost. So examples of alternative payment models might be accountable care organizations. One of the ones that's been very popular for decades, but increasingly so, is a patient-centered medical home. Or over on the far right-hand side, it might be something like a bundled payment for a knee replacement. So here's why I think this is important for population health. As on the left-hand side, under the 2011-2014 scenarios, I don't think the providers under some of those payment schemes are going to be looking to partner with population health. But as those providers move further to the right-hand side, the 2016, 2018 goals, and they get into more of these alternative payment models, they're going to need some expertise that they don't have, which is truly caring holistically for the health of that patient. They're going to think they know how to do it. Most of them do not know how to do it. And so I think there's more opportunities to partner as providers in the healthcare scenario move farther to the right. You may have seen a slide similar to this. I think it came from one of Don Berwick's presentations. It's actually from the Massachusetts Budget and Policy Center. And as you compare budgets from year to year, as healthcare costs rise, it means we have less to spend on other services, education, environment, recreation, and other services. And I don't know if any of you saw the story about China, Maine. I first heard it when I was working in Aligning Forces for Quality. The state of Maine was one of our communities. China, Maine is a small community of about 4,500 people, and they have 11 municipal employees. And the city manager, whoever is the head honcho there, is really having a problem because as his healthcare costs are rising for those municipal employees, it means he can't fund schools, he can't fix the potholes in the road, literally. So China, Maine is experiencing exactly what this graph shows. In fact, the gentleman said in an interview that the healthcare cost for one employee was his entire annual budget for parks and recreation. So that's the problem of rising healthcare costs, and this you're probably very familiar with. It came from an article by Steve Schroeder, who drew from earlier data from an early article by Michael McGinnis and colleagues. Even though healthcare costs are rising, the effect or the impact of healthcare on health outcomes is much less than many of the other domains. So this is the disconnect that we're living with, and while it's not good news, I think it's creating some opportunities in population health. So I have been using that term population health, so maybe we ought to define it. Now, if you were to ask those providers and those accountable care organizations about population health, they would say it's taking care of the patients who come to my health system or my clinic. I have to take care of those patients. I was at a meeting of Community Catalyst just a year or two ago, and some of the grantees were talking about their population health projects. One of them was in early education, taking care of education for very small children. Another was in getting returning veterans needed mental health services. And a third project was about helping incarcerated moms maintain their family relationships while the moms were in jail. So which is population health? I say it's all of the above. But you'll notice there's quite a difference there in how they're thinking about population. Now at NQF, our definition here, you see it, population health, is adapted from Kindig and Stoddard. We also have a definition of population or total population, and this is adapted from an NQF Commission paper that Jacobson and Teutsch authored. And at the end of my slides, I have these resources listed if you're interested in these reports. And the total population is all individuals in a specified geopolitical area. Now, a geopolitical area can be a zip code, a precinct, a ward, a metropolitan statistical area. And the reason we went with geopolitical is, number one, it enhances the chances that you're actually going to get a relevant data source to look at the population in that geopolitical area. But also, program funding and government regulations are often defined with geopolitical boundaries. So I want to talk a little bit more about partnership in population health and measurement in population health, and I'm going to do it in the context of an NQF project that we had. It's funded by HHS and ARC, and it was, the goal of the project was to develop a guide that could be used by any entity, any organization trying to improve population health at any level. So the deliverable is what you see at the top in italics, is an action guide. Now, there's already a ton of great resources out there, so do we really need another action guide? This actually compiled all of that information and was like a guide to the guide, and I have a reference also for this on the back page if you're interested in it. So the action guide included definitions of key terms, 10 elements, best practices, and tools. Now, the really cool thing about this project is after we developed the action guide, we got to work with 10 organizations out in the field, 10 groups out in the field, trying to do this work, who kind of kicked the tires of the action guide to see, was it helpful, was it actually useful? So here's a list of what we imaginatively call the field testing groups, and I'm not going to talk about all of them. I will tell you they are not a random sample because they chose to apply for this program. They did not get any money. They got technical assistance and a couple of meetings out of it. But I want to point out the diversity in this group. For example, the Geneva Tower Health Collaborative. That group is trying to improve the health in one apartment building that has 183 apartments in it. It's in Cedar Rapids, Iowa, and housed in that building are low-income elderly and disabled adults. The Oberlin Community Services in Oberlin, Ohio started off as a food bank. They've now expanded their services. And you can contrast those two groups with the Trenton Health Team in Trenton, New Jersey. They have 2 hospitals and 29 community organizations. They, in the past, I think, year and a half, became a Medicaid accountable care organization, and they just got a 5-year grant from Trinity Health to work on some of their identified priorities. Now, one of their priorities is bringing more fresh food and farmers markets to Trenton because it is a food desert. And when we were there on a site visit, they took us around and they took us to the local bodega. And they took money from a small amount of money from a grant, and they got fresh fruit cups to sell in these bodegas for $1 each. And it's been ongoing now for some time. The fruit cups always sell out, and they monitor how many fresh fruit cups they put in there. This is just a very, very small step, I know, but it's part of a larger plan of what they're trying to do in Trenton, New Jersey. Now, down at the bottom of the slide, I've written national problems, local solutions, and that came from my work on Aligning Forces. Aligning Forces was, again, funded by the Robert Wood Johnson Foundation. It was 16 very diverse communities, some entire states, some as small as one county, all trying to improve the health care in their communities. They were an incredibly diverse group of communities, just like these 10 field testing groups. So even though the problems that we have are national, I think what's critical is that we look at local solutions or local adaptations, because the context, for example, of what's going to work in Boston is not the same as what's going to work in Albuquerque, New Mexico. So think national problems, but local solutions. And I think anytime we talk about population health, we've got to think about the diversity, just like the diversity in these field testing groups, the diversity of the people, the individuals, the organizations that are trying to do that work. 'Cause there is no single one-size-fits-all. There is no single silver bullet. So these are the 10 elements in the action guide. We originally had them in just a 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 checklist. And the field testing groups came back and said, that's fine, it's not how it works in the real world. And that top bar, collaborative self-assessment, which we put as the first step of those 10 elements, was figuring out partnerships. Do you already have partnerships in place? Do you need to form partnerships? Do you have a coalition? Do you have a collaboration in your community where you're trying to make a difference, however you define that community, what your total population is? Who's at the table and who needs to be at the table? And then you can see there's a number of other steps here, and I'm going to talk mainly about that top bar and then also about the performance measures. And I'm going to look at my notes, make sure I haven't forgotten something. So let's talk about partnerships. In my quality improvement work, I have seen an incredible evolution of partnerships in different settings. My first work was in hospital collaboratives, and those were kind of like interdisciplinary teams. And going to a hospital in 2005, I know this is hard to believe, but going to some hospitals in 2005 and saying everybody needs to be a part of your team was fairly radical. But it turned out to be a very good thing. One of the stories came from a Florida hospital who was trying to figure out how to shorten the amount of time when a patient presented at the emergency department with a particular kind of heart attack, and they had to get that patient to the cardiac catheterization lab, and every minute counted. Well, it was very helpful that they had included someone from transportation on their team, because that was the person who could tell them why that elevator was locked down after hours and on the weekend, and why if you had a patient on a gurney, you had to add X number of minutes to go find an available elevator to take that patient up to the cardiac cath lab. They learned something by having this interdisciplinary team. This multi-stakeholder environment, I think it's what we have at NQF. It's a lot of people with different perspectives, and everybody has to be at the table. Aligning Forces for Quality certainly was multi-stakeholder, so that was kind of like the next iteration of partnership for me. In Aligning Forces, no matter who got the grant from the foundation to be that community, and some were housed in medical systems, others were not, others were community organization. Massachusetts Health Quality Partners was one of those organizations. They had to have all the stakeholders at the table defined as people who give care, which is providers like physicians and hospitals, people who pay for care, purchasers or employers, and people who get care, patients and consumers. And when those groups brought all those stakeholders around the table, the conversation changed immediately. Now, we can talk about the next step in that evolution, which is multisectoral, or I've also seen it multisectorial. And this is when you have education and transportation and healthcare and the judicial system, and I'm going to leave out a lot of names, around the table to talk about population health. That is the next level. Now, challenges when you invite people not like you to the table. First is language, and I'm not talking about which language you're speaking. It's your terms are different. You define things differently, and you can be using the same word, and you are on completely different planets. That's a big challenge. Competing priorities and agenda. You can invite an organization, a representative of an organization to the table, but do you know how hard that is to leave your day job behind? Because that is really what's driving your thought process. It's where you live mentally. Reaching consensus, we've talked a little bit about that, and then I want to talk about commitment. So when you go into when you're trying to build partnerships, from my viewpoint, I think you go through 3 stages, and it's convening, consensus, and commitment. And each one is a higher level and more challenging. Convening people is simply getting interested parties around the table, and a lot of people do that well. They are conveners. But have you ever been to a group where it seems like all they do is convene? They never quite get to the doing part. Well, that means they need to go to that next step of consensus, and that's a real tricky one, because when you want to reach consensus, it means you're going to say no to somebody. And the people who are really good neutral conveners don't want to say no to people, so they just keep convening. But when you move to consensus, now you're starting to set priorities. And then the last step, which is the toughest one, which is commitment. And the most highly functioning partnerships or collaborations that I've seen are those where stakeholders at the table are willing to commit some sort of resource to the common good. It could be money, it could be in-kind contribution, it could be resources, it could be a loan of staff or performing some activity. But convening, consensus, and commitment, you're going to have to move through all stages as you're working on your partnerships. Want to slide over to the measurement side of the house. In NQF, as I said, our measures are organized. Basically, we use the National Quality Strategy as an organizing framework. These are some examples of current measures that are NQF endorsed out of our health and well-being portfolio. And so I would draw your attention to that column that says primary prevention and or screening. Often in population health, the measures look kind of clinical. And those are those kind of measures. It's about vaccinations or immunizations or screening for men or women. But if you move over to that right-hand side, it's modifiable social, economic, environmental determinants of health. Now we're looking more like population health measures. And the question is, when we look at population health, which are the right measures? Which are going to be those best measures? Now, at NQF, we have over 500 measures. When we looked at the field testing groups and asked them how many measures these 10 organizations were using, the count was 391 measures, just 10 organizations. So you would think, well, we have more measures than we could possibly need. Not so fast. We have a lot of measures, but do we have the measures that we need? The field testing groups, like many others, reported some real challenges in getting the measures they need to look at their priorities, to measure how well they were doing with their priorities. And here are some of the challenges. We're having this population health team. The field testing groups and the committee are meeting in NQF, at NQF, April 14th and 15th. If you want to listen in virtually, you're more than welcome to. I've got a resource for you at the end. We're spending the entire afternoon talking about measurement. We're spending the entire next morning talking about data. That's how critical measurement and data are for these people. So here are some of the problems. It's the availability of relevant and granular data. So depending on how you define your population, can you actually find data just about that population? So for example, the county health rankings in Wisconsin are fabulous if you're looking at the level of a county. If you want to go more granular, you need other data sources. The aggregation of different data sources, everybody's got their own data, but can you actually aggregate it or combine it? And then the capacity to validate or analyze existing measures. Do you even have a database where you can hold all this information? If you think a lot of the people working in population health, they aren't data analysts. They don't have that capacity. And so somebody's got to help them do that. Obviously, measures change because priorities shift. We don't have the relevant measures. And then this last one is measures that someone else is asking you to report on, maybe because it's part of your funding, versus the ones that you really want to report on. One organization said they had to report 40 measures in this particular project. They only cared about 12 of them. That's called measurement burden. So let's talk about a couple of things that are needed, particularly from Boston University, but also others. I think we need to be modeling good behavior. And by that I mean, in saying that population health is a partnership and that we should move towards partnerships that are multisectoral, do you do that within the School of Public Health? Do you do that in your curriculum? Is that how you're training your students how to think? So that would be, I think about my experience in GW, and I think we were pretty siloed. I don't think there was as much cross-fertilization as there needed to be. And I think for students to be prepared to go out and do this kind of work, that's what they need to be thinking about. Research is so desperately needed in so many areas about the measures, about the data, about the unintended consequences of measure. And another thing we don't have great evidence about interventions. So if you wanted to measure something, do an intervention, measure it again to see if it works, we don't even have a lot of really great evidence on the interventions. And an active partner, this is you all being an active partner with these population health organizations, providing the needed expertise. So for example, one of the field testing groups said they were going to try and partner with the local school, college or university to do the data analytics for them, to help them understand what data were out there, and to do the analytics to help them understand how they could use it to tell their story about the work they're doing in population health. This last one, explore opportunities, is perhaps not as relevant here in Massachusetts and Boston, but there are some tremendous opportunities there. Some of it's coming through the federal government and opportunities from the Centers for Medicare and Medicaid Innovation. They are doing phenomenal projects, and I know that Massachusetts is involved in a lot of those. But I think we always have to be tuned into the opportunities that come our way, where we might have a role, where we might have a part. And then the last thing that I didn't put on the slide that I thought about is I was at a conference last week on palliative care and hospice care. And I was walking through the poster sessions. You always do that at a conference. I always look at the posters. There was some great work in those posters. And you go to every conference and we always see those posters. Isn't there some way we can start to knit those pieces together? Isn't there some way that we can look at these research projects, and some of them done with fairly small sample sizes, fairly small groups, but if we took them in as themes, could we not, here in the academic environment, start knitting together those pieces to help us understand more clearly where we need to go? It was just a thought as I was walking through the poster session. So here's a couple of resources that I mentioned that are available on my slides from NQF. And at this point, I know we had a whole hour together, but I wanted to wrap it up because I would much rather have a discussion with you than have you listen to any more presentations. So thank you very much for your time. Not too bad. And do we have any questions?
Thank you.
I actually tweeted out one thing you said, which is, do we teach our students how to think? Which I actually think is quite important, and I worry about that all the time. I'm curious about your insights about how do we teach our students how to think around issues of measurement and the issues that you care about. I actually think we're probably particularly bad at teaching our students how to think about things like measurement. I think it's part of the curriculum where we do rote and here's how it is. Mm-hmm. So I'm wondering if you have any insights on that would help provoke us as we think about innovating in our educational program.
Let's see, when I was at GW in my spare time, I taught healthcare finance on and off for 5 years. And so it was very interesting because you would think that it was a little accounting, it was a little managerial finance, it was a little bit about reimbursement in healthcare, and you would think that finance would be so black and white. You know, it's numbers. And the students would learn to do like a net present value, and they'd be thrilled because they thought that's all they had to do. And I said, no, that's just the beginning. Because I said to them, what you have to understand is what's behind each of those numbers. And so when I think about trying to teach students about measurement, which is, let's face it, that's not going to be a very exciting topic for them. It's really about what measurement can do. It's about improvement. So you want to make a difference. I don't care what you're doing, whether you're leading people or you're doing a population health project or whatever you're doing, you want to make a difference. And so my question to the students is, how do you know? How do you know? You want to do well in a project, you want to lead people well, you want to achieve this in your organization. How do you know? So I think going back to metrics and measurement as a basic tool is one way to introduce it, because we're trying to I had to teach certain subject matter to the students. They had to learn certain skill sets. But what was more important is why they understood why that knowledge was important, what they could learn and what they could show. And certainly in finance, which it has a form of measurement, I see a budget as a tool to measure how well you're doing. It's just a numerical representation of healthcare services being provided or services being provided to someone. So I think for me, if you want to do something well, how will you know whether you're doing it well? And I think that's a form of measurement. But if somebody else has a different idea, I would welcome hearing it.
This is another question, not so much another idea about that. 2 questions that were provoked with the example slide you showed with community level as well as the different levels of measures. Mm-hmm. They both seem really challenging to me in different ways, and I wonder how your groups have grappled with them. One is, if you have multi-sectoral folks around the table, housing, transportation, et cetera, do you ever think together about systems or structural level measures that highly affect individuals in that captive population, but are measured at the systems level? So, easy example might be proportion of homes or lead in the water supply, mm-hmm. as opposed to number of kids with high lead levels. So there are community level variables, but that affect individuals, but they're measured at the systems level. Capturing really what it means to be multisectoral in our thinking, right? To not just be thinking about how things play out ultimately at the individual level.
Yeah. I think if I'm understanding your question correctly, one reason I put up the Donna-Beatty structure process outcome mm-hmm. is I think each of those kinds of measures have a role. Sometimes the measures we have are driven by the data that are available, right. Quite frankly, and one reason you say, well, why don't we have better measures, Marcia? Well, my simplistic answer is we need the data. To get better measures, we need better data. So I think that, if I'm hearing you correctly, there is a role for each of those type of measures, and it's a way to communicate information about the problem. And when you think about dealing in the multisectoral environment, I think that's one of the keys, is being able to communicate in terms that they can understand. So, but you have to do almost what you just did. You have to give that explanation of, here's what this measure represents, and here's how it's related to the issue at hand. Data are very good for describing issues and problems. The enormity of, the shifting demographics in the U.S. and how it was affecting palliative care. Just missed my train of thought. So data from performance measures are good for showing improvement. Mm-hmm. And then, of course, on top of that, you can layer the personal story. But I think the different types of measures all have a purpose.
So I guess let me try asking it in a different way, because in a way, it's not the Donabedian sense of structural that I meant, but more the social determinant sense. I just wonder if healthcare providers, payers, at your table, mm-hmm. are ever interested in using and seeking data that exist multisectorally, that is out in the community, from police departments, transportation, that they know have a huge impact on their population's health, but they're not measured at the individual level.
Yeah.
Maybe that's just beyond the scope of National Quality Forum. But.
Well, perhaps, but I'll give you an opinion on it anyway,
yeah.
even though it's not an issue of National Quality Forum. I think that's an exceedingly difficult conversation to have, and we see it in the providers saying, this is the world of what I can control. And I know there's these whole other series of issues affecting my patient. I will confess to you, I'm confessing again, I will confess to you that in the 20 years that I worked in San Diego in healthcare, it never occurred to me to think about what the patient's life was like when they went back home. That was just not in my wheelhouse at that point in time. I think to get physicians, I shouldn't say physicians, I think to get healthcare delivery more engaged in those conversations, I think the payment changes that are forcing them to be accountable at a different level are the opportunity. But I would say, unfortunately, I don't think those are common conversations except within select health systems in some very forward-thinking providers. But I am hopeful that some of the shift in payment will create more opportunities for the partnerships where you can go in and say, I know you don't know how to do this, but we know how to do this, and here's how it's going to help you manage that patient's care.
Yeah,
Okay. Yes, sir.
So thank you very much for this. This was very interesting. So my research is largely about health reform politics, mm-hmm. And I'm struck when I dig into the debate that it's often, or it's very rarely about health. It's much more about healthcare costs or health insurance coverage. And one reason perhaps is that it seems to me much easier to boil down coverage to a single number, percent covered, healthcare costs. I mean, I think there's measurement issues there, but the media will report, politicians will say, here is how much we
They will still
spent.
make up the numbers even though there are measurement issues there, sure.
So it strikes me as a population health measurement challenge in some ways. So the question is, how do we, who care about population health, how do we compete with those other measures, or how do we engage the broader public in that conversation?
Oh, I'm glad you asked an easy one. Let me think about that. Well, part of the issue is just the slides that I showed where healthcare is so dominant in the costs. And the only sort of good news out of that is the pain point is so bad right now that people are paying attention. I don't have an easy answer for that. I think it's, just as in my earlier days in healthcare, I never thought about the effects of the patient's home life and their personal situation, how critical that was to their health care. And I think it's through data or through personal stories helping the healthcare side of the house to understand the relevance. Some of this is already going on, and one of the examples I was thinking of is in Hennepin County, Minnesota. Hennepin Health is a Medicaid managed care plan that cares for the highest utilizers of care in that area. And there's a woman named Nancy Garrett who's with that program, and she does a wonderful presentation on how they have brought in representatives from housing and community services that are co-located in their clinic, because for them, a win with a patient may be getting them stable housing. And I'm thinking also of Jeff Brenner's work in the Camden Coalition and his work with superutilizers. Now, that work tends to focus on the highest cost patients, so there initially was an incentive there. But I do think looking at programs like that to say, if the most urgent need is stable housing or other issues, personal issues, transportation issues of the patient, at the end of the day, that's how we need to look at it. Now, Hennepin, I just read an article about Hennepin Health, where they were able to reduce emergency department visits by 9% for this group of patients, so they could take that money, because they were in a Medicaid managed care, kind of a more of a controlled environment, take that money and pay the housing people and the community services people. So I'm a healthcare finance person. I think it's a lot about the money. It's being able to get into a situation where some of those dollars saved can be redirected in another direction and show success in that way, perhaps. Yes.
Thank you. But what you just said made me think that, would NQF ever go towards measures in that way? So, you might have a pulmonology or cardiac measure about treatment or follow-up appointments. Could you ever see NQF going in a way that a measure could be collaboration with, community services, housing, et cetera?
Yeah, I think, I'm not sure that I can see NQF doing that, but I can certainly see others doing that. NQF kind of grew up in the clinical performance measure quality world, and we've been talking a lot about what about other types of measures. For example, measures of access. Well, that doesn't exactly fit in our existing rubric, but shouldn't we be having better measures of access? And I think we were talking about that today a little bit. I do think that measures of, say, collaboration are important, and there are some resources out there. In fact, there's probably some in that action guide, because, for example, one of the things you may want to measure in your formation of partnerships is the strength of that partnership. How much do the partners value what they're doing? So you could have a measure that would have to do with the inclusion of community services or the different sectors. I don't know that would necessarily come to an NQF, but I think those kind of measures are sorely needed for that environment. I think they serve a very specific purpose in that environment. It's very intriguing to think about that. Yes, sir.
Thank you for your talk. One of the things I didn't learn as a student was that the measures are not socially neutral, and the data we collect reflect our beliefs, our bias, and power structures that exist. Do you have any insights of how we protect ourselves from our own biases and possibly the power structures for the conclusions that we reach?
Why don't you let him keep the mic for a second, because I want to ask him a follow-up. That's really intriguing, and I do not disagree with that statement. Give me an example of how that might play out. If you could. It will help me think about that.
No.
Is that okay? Okay. Because I'm not disagreeing with you. I'm just trying to think of a scenario where that.
I was thinking one of the first books the non-statistical books about measurement was The Mismeasure of Man by Stephen Jay Gould, where he talks about the misuse of statistics and the racial bias of the first geneticists and statisticians in the early 20th century, and where they were collecting measurements of skulls to because it reflected their bias that there are differences between races in terms of intelligence. So I assume that similar things may exist in healthcare policy, where we see disparities in race, income, and
That's very interesting. I do not have a good answer for you. I think that's an interesting question, and I think it's on do you have a comment about that? No. Okay, I was looking for, if someone wanted to make a comment, that would be okay. And I think we're talking about a couple of different things here. I was going to go to adjusting measures by different patient factors in order to disaggregate what was happening with populations. And I felt a little guilty that I did not talk about disparities or equity or vulnerable populations in a talk about population health and measures. But when you're talking about the folks who live in the Geneva Towers, we are talking about vulnerable populations. So, but I felt a little guilty not putting that more in my presentation. So I was thinking more about risk adjusting or adjusting measures or looking at disaggregating measures by patient characteristics so we could see where the disparities were. But I think your comment is different than that. You're talking about the biases up front. And I have to admit, I do not have a good answer for you, but I'm going to think about that. Well, and if you could tell me afterwards the name of that book, I'd like to look at that book. Yes, sir.
I'll give you one.
Oh, good. Okay. He's got one.
Yeah, the interpretation of the diabetes control and complication trial, type 1 diabetes, tight control versus not, the measure that made it popular, that made tight control popular, was that you reduce the hemoglobin A1C. Mm-hmm. The reason patients hate tight control is because they can have, rare occurrence of severe hypoglycemia, which is a technical term which means that you lose control of your car, crash into somebody, run over somebody, and have a really bad day. They may value that measure much more. So the bias in what we measure that determines then what we do is there.
Believe it or not, we didn't talk about in terms of car crashes, but we just had that discussion at NQF. There was a diabetes control measure that came up, and it was how it came out in the conversation, or how it came up in the discussion, was really about who should be excluded from that where it may not be appropriate, versus is this a measure that truly can truly be applied to that denominator of patients from this age to this age, or are there groups who should be in the exclusions because that tight control is not necessarily going to be a good thing? So that kind of discussion absolutely comes up in the conversation when we talk about measures. Yes, sir. Oops. Is that me?
I had a question about, you had mentioned 500 measures that have been endorsed by the National Quality Forum. Mm-hmm. Is that a concern to this organization? And is it something that you're working on, a la Michael Porter's recent piece in the New England Journal, where he is arguing we need to reduce the number of measures, and it seems like you might be going in the opposite direction. Do you care to comment on that?
Oh, I would love to. It's a great question, and I'm delighted that someone brought it up. And in case you hadn't seen Don Berwick's JAMA Viewpoint, March 3rd, and typical Don Berwick, so thoughtful, so insightful. I always read his stuff, and I so rarely disagree with him. And he was talking about how the pendulum has swung too far in the accountability and the use of measures in this era of healthcare. He called for a new era of healthcare, and he had 9 recommended changes. And his first recommended changes was a reduction in the mandated measurement by 50% by this point in time and 75% in this point of time. And he literally called for CMS and regulators and I think health plans to work with NQF to do this. What you're talking about is a very real problem. So if we look at the world of measurement, is there a tsunami of measures or is there a desert of measures? Well, it depends on your perspective. If you're in a hospital, a primary care practice, you probably would vote for the tsunami, because what's becoming very apparent is there a measurement burden for all the measures that have to be reported. And if you didn't see it, there was just an article in Health Affairs within the last 2 weeks by Dr. Lawrence Casalino, Larry Casalino and colleagues, and they did a survey of MGMA members, the Medical Group Management Association, on measurement, what the resources were being spent on measurement and the provider hours that were being taken away from patient and the cost and the numbers were staggering. This measurement burden is real. So yes, I do think 500 measures is not the problem. Because if you went to a library with 500 books, you wouldn't care, because you would pick out the books that you wanted. 500 books would be great. The problem is it's not a library. Somebody else is telling you what books to check out in these mandated requirements to measure, and that's where I think it has really become burdensome. I think looking at which measures are making a difference, and that's from various perspectives of different stakeholders, is important. I think looking at reducing measures that are in use or being mandated in programs is absolutely something that we need to be doing, and I can tell you it is very much a part of the discussion that's going on at NQF is how can we help solve this problem. Now, the only reason I mention the measurement desert is it's real. If you have a certain condition and want to know about the quality of providers or outcomes from treatments, you may have zero information because the measurement is not there. So for some providers, there's a tremendous tsunami of measures that is causing burden. That needs to be addressed. But on the other side, we've got measure gaps, and we desperately need good measures to give information to providers, to patients, to everyone that people can use for different purposes. So thank you for bringing that up. It's a big issue and definitely on our radar at NQF. Yes, sir.
One more question.
Okay.
Thanks. I enjoyed your presentation. So we published a study not too long ago in which we looked at the Medicare Advantage star rating system, 1 to 5 stars. And there are now teeth in those measures, performance measures, in terms of reimbursement being affected, the ability of a business to expand in bonuses. So we essentially looked at geography as a predictor of the star ratings and found that it blew out a number of variables in the model, that in fact it was geography that turned out to be one of the most important predictors of the star ratings.
Interesting.
What does this say for the way in which CMS is currently evaluating these plans? And should geography be taken into account?
I'm going to be very prudent in my response since you're asking what should CMS be doing, so I'm going to try and be politically correct. I assume you have shared this information with CMS, this study with CMS. And I think you're pointing to another problem that we have that we discussed this afternoon is the variables that we have to use in measurement. We just don't have the data that we need. And in some cases, perhaps we're not looking at the appropriate variables. So I would encourage you to keep speaking to CMS, keep communicating with CMS about your findings, and it may be that I will say this about the people at CMS in particular that we work with NQF. They are true partners and they are true collaborators. And I am saying this in all honesty. I cannot tell you how many conversations or discussions I've been in with some of our folks from CMS with whom we work most closely, and they have said, that's great information. You know, we're really trying to improve. We're always doing this in an iterative style. So I would encourage you to keep talking with them. My experience has been that they truly are trying to listen and to make appropriate changes where they can, and I find them to be really important partners. So thank you all. Thank you very much.